Hi, I'm Dr. Jack West, and I'm a medical oncologist and associate clinical professor in medical oncology, thoracic oncology specialty at City of Hope Cancer Center in the Los Angeles area. And I'm very happy to be joined today by two of my excellent global expert colleagues from around the country. Dr. Charu Aggarwal, who is the Leslie Heisler Assistant Professor of Medicine at the University of Pennsylvania School of Medicine in Philadelphia, and Dr. Ben Levy, who is Associate Professor at Johns Hopkins School of Medicine in the Baltimore area. So thanks, both of you, so much for joining us.
Thanks, Jack.
Thank you, Jack.
We're going to be talking about several issues that came up as leading questions at ASCO 2019. And I would say that this year there were not a lot of immediately practice-changing findings, but there were some provocative results that I think are likely to lead to changes in how we think about various populations, and potentially we'll have new treatment options in the coming year or so. So let's start with a setting where it's not really a novel treatment, but it's a population that may be a candidate for chemotherapy after surgery. And this is a group of patients with a stage 1 non-small cell lung cancer, where we typically consider conventional chemotherapy as an adjuvant or post-operative treatment to reduce the risk of the cancer coming back, primarily in patients where the tumor is at least 4 centimeters in size, because we think of that as a higher risk. Now, there was a Japanese study that was presented at ASCO this year that looked at retrospective results, that is, looking back at about 1,200 or so patients from Japan who had node-negative stage 1 cancers, and they looked at these smaller ones and tried to see whether chemotherapy that was given or wasn't given made a difference for them. And what they found was that there were a group of patients who had certain high-risk features, such as pleural involvement, that lining around the lung, or visceral or vascular invasion, or other certain features that were seen in about half of these patients with smaller tumors. And in these patients, the outcomes in terms of relapse and survival was not as favorable. But importantly, it seemed that chemotherapy, if given to these patients with higher risk features, was associated with better survival. That was not seen in the patients who didn't have these higher risk features. Now, that said, this was a retrospective series looking back. It was not a design trial. And this was a Japanese study. And we also have some understanding that the biology of the cancers in Japan may not be the same as in other parts of the world. So coming out of ASCO, what did you both take from this? Is this going to have an impact on how you talk to your own patients who have a smaller cancer? Are you going to be thinking about recommending chemotherapy for someone with a 2 or a 3 centimeter cancer, particularly if it has high risk features? And maybe I'll start with you, Ben.
Yeah, I think it's tough to base treatment decisions on retrospective data. And as you mentioned, I mean, they certainly identified this high-risk group and found that chemotherapy did benefit these folks in looking back retrospectively. Interestingly, the patients who got chemotherapy happened to be younger than the patients who didn't in this high-risk group, and they also were more likely to have adenocarcinoma. And also, these are patients in which the physician decided that they weren't going to get adjuvant chemotherapy. This is a group that, was probably perhaps more fit. So I'm not sure that I would take anything away from this. And I don't think this is going to change the way that I approach a patient with a stage 1 lung cancer. We need to remember, at least from the LACE meta-analysis, that there is a detriment to chemotherapy in the stage 1 tumors, at least the 1As. So I'm not going to take much from this. It's interesting, and certainly we would need prospective data for me to absolutely, or at least change my approach for these patients.
Charu, what did you take from this? Were you impressed by it, or are you still inclined to wait on other data before thinking about changing your recommendations for your own patients?
So I was not terribly impressed by these data. In addition to what both you and Ben have said, only a quarter of the patients actually went on to receive chemotherapy. And if we were to examine what chemotherapies these patients received, actually a great majority of these patients received non-standard adjuvant chemotherapies. I mean, they were treated with monotherapy with either UFT or S1, and only about, I think, 40%, 35 or 40% received platinum doublet chemotherapy. So I don't think that these results are really largely generalizable anyway, based on the chemotherapy regimen that was received by these patients. Therefore, I don't believe that at this time we have enough evidence to change our current practice. I think, for the greater than 4 centimeter tumors, I still have a conversation with the patients, but I don't think at this point in time enough to change my management.
Fair enough. I think I would maybe have some discussion with the patient, particularly one who's motivated and anxious and has several high-risk features. I think that when we think about how we came to this 4 centimeter number, it's probably more of a continuum. It's not some true binary line in the sand. And so I don't think there's anything that's particularly magical about that. But I think both of your points are very well taken, that this is not usually a level of evidence that would sway us a lot or change a standard of care, certainly.